Imagine for a second, just trying to casually read your morning news, but someone is actively blasting you with a high-pressure fire hose.
Oh, wow.
Yeah, and the building you're sitting in is actively burning down, and, the fundamental rules of physics just keep changing every 5 minutes.
That sounds like a nightmare.
Right. But that is the exact reality the global medical and scientific communities face during a sudden public health emergency. Welcome to today's deep dive. We are opening up a really fascinating chapter by Sandra Long of United Health Group, and it's titled Optimizing Knowledge Management During Crises.
It's just an incredible look under the hood of how the world, attempts to manufacture stability out of just absolute chaos.
Exactly. And our mission for this deep dive is to uncover exactly how these communities transform this crushing avalanche of raw, disjointed data into life-saving knowledge, and like how they actually share it globally without the entire digital infrastructure just totally collapsing.
Which is harder than it sounds.
Much harder. And while this source specifically anchors its research in massive healthcare crises, so we're talking examining responses to COVID-19, Ebola, HIV, the mechanics of what we are talking about today, well, they are pretty much universal.
Oh, absolutely.
Learning how to extract, verify, and apply critical information without drowning in info overload is, frankly, the ultimate shortcut to being well-informed in literally any high-stakes scenario you might face.
Because the architectural principles of managing information under extreme pressure, they remain identical. It really doesn't matter whether you are trying to stabilize an international hospital network or, simply trying to navigate a crisis in your own industry or even your personal life.
Okay, let's unpack this because the text points out a rather grim historical reality. Humans have traditionally dealt very, very poorly with unexpected disease spreads.
We really have. I mean, historically speaking, it's not a great track record.
No, not at all. If you look back at historical records from ancient times or even more recent outbreaks right before the modern era, the accounts are just filled with these vivid descriptions of death and societal trauma.
Right.
But they offer almost zero actionable epidemiological data about how healers actually managed or contained the spread effectively. It has really only been in like the last 300 years that we have developed rational public health practices.
And that leap, from just leaving behind traumatic stories to actually leaving behind actionable science, that relies entirely on a foundational concept that the source material meticulously defines.
And what's that?
Well, in a crisis, you have to separate data, information, and knowledge. They are functionally completely different assets. And treating them as the same thing, well, that's exactly how systems fail.
Yeah, to understand how strict these definitions are in the text, I like to think about it through this analogy. So think of data as essentially just a giant pile of bricks dumped on an empty lot.
Just completely raw and unorganized.
Yeah. Exactly. Unorganized, raw facts. So, like a list of hospital admissions or just a tally of positive test counts.
Yeah.
Then you have information. Information is taking those bricks and organizing them by size and color and putting them alongside a blueprint.
You're giving it context.
Right. You've contextualized the data by tracking, say, which zip codes those admissions came from or the age brackets of the positive tests.
But, and this is the kicker, you still don't have a shelter.
Exactly. You're still standing in the rain. Knowledge is having the engineering know-how to actually build a house out of those bricks that won't immediately collapse on your head. Knowledge is understanding the incubation periods, recognizing the long-term severity, and knowing definitively which treatments are effective.
What's fascinating here is how clearly this played out in the very early days of the COVID-19 pandemic. At the beginning, we were just buried under bricks.
So many bricks.
We had raw data flooding in, skyrocketing, emergency room admissions, mortality counts, all of it. But the shapes of those bricks were constantly changing. We had virtually zero knowledge. To turn raw data into a functional house, you require a highly structured engine, which is called a knowledge management system, or a KMS. A KMS isn't just, a database where you dump numbers.
It's more than just a spreadsheet.
Much more. It is a comprehensive information technology framework. It's designed to systematically capture, store, analyze, and instantly distribute contextualized information so that decision makers across the globe share a singular, accurate understanding of reality.
Which is essentially the process of manufacturing knowledge. But here is the massive friction point the text outlines. Once you successfully manufacture that life-saving knowledge, you have to distribute it to the researchers and frontline workers who need it at lightning speed.
And that's where things get really complicated.
Because the moment you try to accelerate that distribution, you trigger a massive collision with patient privacy.
Yeah, it's the structural tension between the sheer speed required to save lives and the rigid protocols required to protect individual identities.
Now, I have to challenge the tech's premise on this. I mean, if there is a highly transmissible, deadly virus actively spreading through a community, shouldn't privacy take a total backseat to speed?
You'd think so, right?
Yeah. Like, if someone is infected and walking around a grocery store, wouldn't the most rational response be to broadcast that information immediately so people can protect themselves and stop the spread?
This raises an important question, and the instinct to broadcast danger is a very natural human reaction. But the source material reveals a completely counterintuitive reality about systems design. If you abandon privacy, your entire knowledge management system physically collapses.
Because humans don't act like rational data points.
Precisely, we are messy. During an outbreak, there is an immense psychological fear of the stigma attached to a novel disease. People are terrified of social isolation or, losing their jobs or being forcibly separated from their families in some quarantine scenario.
Yeah, that's a very real fear.
So if individuals believe their identity or their health status will be made public, human behavior dictates that they will simply hide.
Wow.
They will suppress their symptoms, they'll avoid testing facilities entirely, and they will dodge contact tracers.
And the moment they hide, your data pool completely dries up.
Exactly. Without absolute privacy guarantees, the raw data simply stops flowing into the KMS. And if you don't have data, you can't generate information, and your knowledge production halts entirely.
It just grinds to a halt.
It does. So maintaining that delicate balance, extracting enough granular data to warn the public while keeping the infected person's identity completely anonymous, it is not merely an ethical courtesy. It is a mandatory structural requirement for the system to function at all.
That makes perfect sense, honestly. Privacy is the mechanism that keeps the pipeline open. And the text notes this need for absolute security doesn't just apply to the patient data, it applies heavily to the researchers collaborating on it too.
Oh, absolutely.
The text provides a really striking mechanical example of this with remote work platforms. So during COVID-19, global experts needed to share highly sensitive genomic data and infection models, and they had to do it quickly.
But they couldn't be in the same room.
Right, they had to remain physically isolated to avoid viral exposure. So, naturally, organizations flocked to Zoom. It had these great collaborative digital whiteboards which allowed scientists to spatially map out molecular structures together in real time without being in the same laboratory.
It functioned as a brilliant, frictionless conduit for raw knowledge.
Until the conduit cracked.
Yeah, that was a mess.
There were severe security breaches where private, high-level research meetings were hacked and hijacked. And the moment the security of that pipeline was compromised, organizations had to abruptly tear down their workflows and pivot their entire strategy over to WebEx meetings.
They just couldn't risk it.
No, they couldn't risk the integrity of the knowledge transmission being corrupted by external actors.
So, okay, we managed to secure the pipeline. We established a private, encrypted system where patients felt safe submitting their symptoms and researchers felt safe submitting their data. But fixing the pipeline immediately creates a secondary, much larger problem.
Which is?
Sheer volume and formatting.
Here's where it gets really interesting. Once the pipeline was secure, it became a literal fire hose. The source highlights a staggering statistic. By 2021, over 75% of all COVID-19 research was available in open access publications.
Which is incredible.
It is. That is more than double the rate of previous years. It was an unprecedented global explosion of scientific sharing.
But pouring that much volume into the system actually broke the machinery.
How so?
Because everyone was rushing to publish and share research outcomes to save lives, the peer review process completely bottlenecked. This led to remarkably poor study design slipping through, chaotic research reporting, and a massive lack of global coordination.
So just a ton of noise mixed in with the signal?
Exactly. You had redundant clinical trials happening simultaneously across different continents, leading to wasted effort and deep uncertainty about which treatment blueprints were actually valid.
So we were drowning in blueprints, but half of them were fundamentally flawed.
Yes.
And trying to organize those blueprints brings up what the text calls the Babel problem. Imagine trying to assemble a million-piece puzzle, but half the pieces are cut using the metric system, the other half are cut using the imperial system, and the picture on the box keeps changing every hour.
That is the perfect analogy. The Babel problem is essentially a massive interoperability nightmare. Because global health systems are entirely decentralized. A central KMS is relying on information collected by thousands of distinct public health authorities.
And I'm guessing they don't all speak the same language?
They literally cannot speak to one another.
I imagine a lot of this comes down to basic definitions, right? Like, if a hospital in Milan defines a severe case based on oxygen levels, but a hospital in Tokyo defines it based on lung imaging, aggregating that data into a single algorithm must completely break the system.
Oh, it shatters the system. Automated databases physically cannot aggregate mismatched data strings. The medical coding organizations were frantically trying to keep up with
I
this.
can even imagine.
It was chaos. For example, they had to constantly create entirely new LOINC codes. LOINC stands for Logical Observation, identifiers, names, and codes. It is the universal standard for identifying medical laboratory observations.
Okay, so every new test needs a code.
Exactly. Every time a new variant test or antigen swab is invented in one country, a new code has to be generated, distributed, and adopted by every other database on Earth so the lab results register correctly.
Because otherwise the database just rejects the input as an error.
Right. And compounding all of this was the fact that the global system was already in the middle of a notoriously messy transition from the ICD-9 to the ICD-10 standards. Yeah, these are the International Classification of Diseases codes. And they aren't just updated lists. ICD-10 is a fundamentally different structural architecture for logging diagnoses.
Oh, wow.
So if you are an epidemiologist trying to track pandemic trends, but half the world's servers are formatting data in ICD-9, the other half in ICD-10, and some regions are using unmapped emergency exception codes.
Your clinical records are entirely fragmented.
Completely.
The human brain simply cannot manually untangle billions of mismatched alphanumeric codes while patients are actively waiting for care in the emergency room. We were completely overwhelmed by the tidal wave, which meant we needed a technological cavalry to come to the rescue.
Yeah, to triage that level of systemic failure, technology had to step in not just as a tool, but as the primary filter and safe harbor for knowledge management.
So what does this all mean for the actual practice of medicine? The text dives into utilizing natural language processing, or NLP, to mine social media. It talks about deploying telemedicine architectures and even using autonomous medical robots for patient health education.
Which is pretty sci-fi when you think about it.
It is, and I have to push back here, honestly. When terrified patients are isolated in a sterile hospital room with a novel virus, aren't we losing the crucial, empathetic, human element of healthcare if we route their care through a screen or replace a nurse with a robot?
The loss of human connection is a deeply felt consequence, and the text definitely acknowledges that, but it insists on the deployment of these tools for one overriding mechanical reason.
Which is?
In a highly contagious outbreak, physical distance is not just a safety measure. It is a structural necessity to stop the healthcare system from compounding the crisis. Every single human-to-human contact is a transmission vector that could take out the very doctors and nurses needed to keep the KMS running.
Wow. So the technology acts as a literal physical shield.
Yes, exactly. Consider the NLP algorithms you mentioned earlier. Natural language processing can scan massive, chaotic amounts of unstructured text on social media.
Just reading through tweets and posts?
Right. It looks for highly specific keyword clusters, like a sudden regional spike in people tweeting about a loss of smell combined with a fever. The algorithm can map a geographic outbreak heat map days before those individuals ever step foot inside a hospital to be formally logged into an electronic health record, or EHR.
It catches the data before the bricks even hit the lot.
Precisely.
And once those patients do hit the hospital, the text notes how vital telemedicine became. It wasn't just about a doctor seeing a patient over a video feed to be safe. Telemedicine applications were designed to feed patient data symptoms, vitals, disease progression, directly into those EHR databases autonomously.
Right, skipping the middleman.
Yeah, it eliminated the step where a human nurse had to manually transcribe notes from a paper chart into a computer.
Which eliminates transcription errors, and critically, it eliminates the paper chart itself. A physical piece of paper passed between a patient and a doctor acts as a fomite, an object that carries infection. You cannot effectively disinfect a paper chart.
No, you can't. But you can absolutely disinfect a tablet computer.
Precisely. That is why the rapid deployment of EHR capabilities in places like the Wuhan shelter hospitals was so critical. They managed a massive influx of emergency admissions entirely digitally.
That's incredible.
And regarding the medical robots deploying them to provide interactive health education in quarantine wards, wasn't just some desperate measure to save staff time.
Right. The text said something really interesting about that.
The source points out that interacting with the robot actually increased the psychological novelty for the patients. That heightened engagement improved their retention of the health education, while simultaneously driving the infection risk for the human hospital staff down to absolute zero.
It is incredible how these localized micro innovations, using an NLP script to read social media or routing an admission signature through a wipeable tablet, they feed perfectly clean, structured data directly back into the macro data pool.
And that seamless integration of digital tools and clinical expertise is not framed as a temporary band-aid to get us through a bad year.
Hmm.
No, the source material proposes that this is the required architectural foundation for what it calls the global learning health system.
The global learning health system. I love the elegance of how this is mapped out in the text. It describes this continuous self-improving loop of systemic knowledge.
It's a brilliant concept.
It really is. It starts with practice, which is the physical reality of what is happening on the ground in clinics and quarantine wards. That practice generates raw data. That data is securely gathered, formatted, and analyzed to become knowledge.
Right.
And then, and this is the crucial mechanism, that new knowledge immediately dictates a rapid, updated implementation of practice. And the loop just continues spinning, operating faster and smarter with every single rotation.
If we connect this to the bigger picture, achieving that autonomous loop is the ultimate objective of health informatics. But to truly realize a global learning health system, the text makes it very clear we need an unprecedented commitment to global interoperability. You have to eliminate the Babel problem permanently.
Which requires everyone to agree on the exact same digital dictionary.
Exactly. It requires the universal adoption of open-source IT standards, specifically systems like FHIR.
FHIR, right?
Yes. FHIR stands for Fast Healthcare Interoperability Resources. Think of it as a universal web-based translator for medical databases. It packages clinical data into standardized digital resources.
Okay, so how does that work in practice?
Well, if a rural clinic using a legacy database logs a new symptom, FHIR instantly translates that data into a format that a modern cloud-based analytics engine in another country can perfectly read and aggregate without any human intervention.
It is all about having the digital pipelines, the automated formatting, and the secure infrastructure fully constructed and tested before the next fire hose turns on.
The system must be capable of autonomous adaptation, because when the next crisis hits, human manual processing will simply always be too slow.
It really profoundly changes how you view the invisible infrastructure around us. For you listening, we have taken quite a journey through this material today.
We really have covered a lot of ground.
We started by looking at unorganized piles of raw data bricks. We explored how privacy protocols physically keep those data pipelines flowing. We untangled the global formatting nightmares of the Babel problem. And we saw how NLP algorithms and disinfected tablets are paving the way toward a fully autonomous, self-learning global health system.
It's a lot to process.
It is. And remember, learning how to filter the overwhelming fire hose of your own daily information so you can actually build a stable house of understanding is just a localized micro version of this exact same global struggle.
Because the fundamental mechanics of organizing reality do not change, only the scale.
Exactly.
And, to leave you with one final thought to mull over as we conclude, there is a specific detail in the source that really highlights the gravity of scaling this up. The text notes that these advanced computer simulations of infection spread are no longer just academic exercises.
Right.
They are the active operational core of national health systems.
They are the models that actively dictate real-world lockdowns, international travel bans, and the massive reallocation of physical resources.
Right. So here is the provocative question to ponder. What happens when the foundational parameters programmed into these predictive models are flawed?
Oh, man.
If there is a simple coding error in the algorithm, or even an incorrect structural assumption about how a virus transmits built into the base layer of the simulation, the system will still confidently output a plan of action.
It doesn't know what's wrong.
Exactly. As we rush to permanently implement this fully automated global learning health system, is it possible that our pursuit of instantaneous, perfect knowledge might accidentally hardwire a disastrous, scientifically validated assumption into international law before a single human expert can catch the mistake in the code?
That is a heavy thought. If the foundational blueprint is flawed, the house comes down, no matter how efficiently the robots stack the bricks. Well, that is all the time we have for today's deep dive. Remember, your world is full of raw data just waiting to be organized into knowledge. Stay curious, stay informed, and we will catch you next time.